Good evening. It is my pleasure to introduce our guest speaker for Grand Rounds this evening, Dr. Mark Andrew Hlatky. Dr. Hlatky epitomizes the individual whom all of us in academics aspire to be, a thought leader. His seminal work in comparative effectiveness and cost effectiveness of cardiovascular treatments, particularly coronary revascularization, has informed the way we practice. Dr. Hlatky is currently Professor of Health Research and Policy and Professor of Medicine at Stanford University. As principal investigator on numerous grants from the NIH and AHRQ, Dr. Hlatky has contributed significantly to science, and in recognition of his long-standing productivity, he was awarded the Outstanding Lifetime Achievement Award by the AHA in 2014, Distinguished Scientist Award by the AHA in 2014, and most recently, Distinguished Scientist Award by the ACC earlier this year. He has also served in many important scientific positions, including serving on NIH study sections, editorial boards of major journals such as JACC and Circulation, and also AHA, ACC guidelines writing committees. Needless to say, Dr. Hlatky is a sought-after speaker at many major international and national meetings, and he has produced more than 300 publications, many of which are highly impactful. So we're indeed very fortunate this evening to have Dr. Hlatky speak on one of his most important work, comparative effectiveness of CABG and PCI. Please welcome Dr. Mark Hlatky.
That's very kind. I appreciate that very much, and it's a great opportunity to come up here and meet with you. And I've enjoyed my visit, even though I understand it gets warmer at other times of the year. But it is nice to be here. So let's see here. Let me see if I can. How do I get this to be the show here? There, right? Okay. Good. Well, I did want to talk about comparative, so everybody can hear me. Okay. Do I need to do something for remote people to hear this, or is this? The audience is all in the room, huh? Okay. This is something that I've been involved with from the beginning of my career, and in a number of studies, and so there's a little bit of a personal element in this. I've worked on a lot of aspects of this, and I want to tell you something about that. But I hope what I can do in this talk is go through a few concepts that will be helpful to you in terms of how do we compare treatments, how do we think about the benefits, and how do I identify and weigh the risks and benefits of treatment for individual patients and come up with individual recommendations. So let's see. Okay. You know, a lot of young faces here, and I think you need to be reminded perhaps of the history of all of this, that bypass surgery was developed in the early 60s, and you know, since then, if you look at surgery today and surgery in the 70s or something, it's quite a bit better now. There's a lot of technical refinements of this, and we know certain things about coronary bypass surgery, and we know that has been tested against medical therapy, and it was done in a number of very pivotal trials, and I came up as a fellow at a time when we had a few enough trials that we all knew them individually and were very familiar with all the protocols. It's hard to do that nowadays because we have so many more studies. But the pivotal trials of medical therapy, I think if you were to look at them today, you would say that the medical therapy was sort of like placebo because most of the things that we consider evidence-based treatment for medical therapy today weren't used in these pivotal trials of surgery versus medical therapy. But nevertheless, we still have some principles that we got from that about how surgery is more beneficial in people with the most extensive and severe disease. PCI was developed later. Andreas Grunzig was a key visionary, and I was lucky enough to meet him when I was a fellow in cardiology at Duke. A great guy, very important, tragic loss that he died at a young age. Ever since then, though, you all are extremely familiar that, you know, the PCI he developed on his kitchen table in Switzerland and the PCI we do today are very, very different things. We have a lot more innovations and gadgets and things that we do. And there have been a few studies of PCI versus medical therapy, and I've listed them here, and also showing, you know, that it's beneficial in reducing symptoms, and in certain cases, especially during acute coronary syndromes, can be helpful for acute events. But for the rest of my talk, I mean, it's a huge thing to say, well, do we need somebody to get revascularization done at all? But that's a different talk than the one I'm going to give you today. The talk I'm going to talk about today is assuming that somebody needs to get revascularized, what's the choice of the procedure that will benefit them the most, and how do we figure that out? So that's a secondary thing, not the primary thing, which is often our main decision is whether they need it at all. So what about the choice of these two procedures? You know, I think if you look in registries and so on, it's very clear that the coronary anatomy and its specific details are highly determinative of whether you get a PCI or a CABG, and it's exactly where the lesions are located and how severe they are. And more often we can't do a PCI because there's more extensive disease than we can't do a CABG. The second thing is, if you look at it, people who have a very extensive coronary disease, many places, left main, usually go straight to CABG, and we don't really try PCI with them, although there's always some arguments about exactly where that boundary is. And the flip side is that in people with very limited disease, there's really not a question we don't send them to CABG. We would do a PCI unless there's some real big problem. And so the idea is that at the two extremes, you know, we kind of know what we're going to do. And that's not where the question is. The question is for the group of people who are sort of in the middle, you know, who conceivably could get either one of these procedures done, which one is the right one for them. And that zone is the zone where most of the comparative effectiveness studies have been done, either randomized or observational. So one of the questions is, you know, which kind of study do we do? Do we really need to keep doing randomized trials or not? I mean, maybe we could get away with you know, some fancy big data analysis of some kind that we just plug it all in a statistical model and come up with the answer. Why should we choose one versus the other? And you have a clinical investigation master's degree program here, so some of the people who've done this, and you probably can tell me the main answers for how we do this. And you know, I think there's a lot to be said on both sides. So there's a lot of clinical databases, like the ACC has some databases, the STS and so on. We have databases, and we can characterize people who are just regular people who come in daily practice and are followed, and we can see what happens to them. And there's a real advantage to that. We don't have to do any you know, formal trial things, so it's much easier to do these. And we can use statistical methods, and I can talk about those in a little bit, to kind of adjust for biases and get rid of the selection factors. But no matter how good you are at it, in the end, there's always some concern that you didn't do a good enough job at adjusting away all the problems. So that's going to say, well, maybe we need to do a trial. And the randomized trial, that's the gold standard. Although interesting, I guess I had an article today in the New York Times about how the gold standard back in the day when we actually had a real gold standard wasn't such a great idea. But anyway, that's what everybody talks about it as being the gold standard, the reference standard for clinical research. And I'd say I could give you a whole talk about randomized trials, but I think the main reason we like them is that they're planned experiments. So we go in with a hypothesis, we collect data in a certain rigorous way, and we also randomize people to make sure that they're comparable on everything that we know about, plus all the things that we don't know about. So we know that if we randomize somebody and there's a genetic variant in the population, that the genetic variant is equally distributed in the two groups within the play of chance, even if we never measured it. But if we went back to measure it later, we'd find that it was equally there. But they're very hard to do. They cost a lot of money. We're not sure about the ethics, and it's very hard. The other thing I should say is if there's something in the middle of this talk, where you want to ask a question or something, I'd rather do it a little more interactively. So that's okay. If I'm saying something that doesn't make any sense, I'd rather hear about it now than at the end, and we can figure that out. So let me just apply to this, turn to PCI and CABG and look at randomized trials. And basically, if I look back at this, we've done trials in 3 different waves, and they correspond to different types of PCI technology. So we had a series of trials that were done with plain old balloon angioplasty versus CABG as the first wave, and then we had bare metal stents became available. And people said, okay, we better try this versus CABG. So there was another series of trials. And then there's more recently a wave of trials that were done with drug-eluting stents versus CABG. And there's probably now a 4th iteration of trials that are based on another technology, mostly on the PCI side, that we want to test against CABG. And this creates something that is a good term for you to remember. It's called the moving target problem. And I'm going to talk about this later in technology evaluation, where what we're trying to do is estimate how good the treatments are that we can do today, but we have to base that on data that we collected on prior versions of the treatment from years ago. And one way to look at that is to say, well, we'll just throw out all the old data, we'll just go in and start anew. But that doesn't seem right. We ought to be able to learn something from the old data, and we ought to be able to apply that to the new data. And one of the questions is how do we do that? So I think that's been an issue with CABG and PCI, but to me, when I look at the data, it seems to me that there's some general lessons that are very clear all throughout all of these trials, and that are probably hold up and are probably real. So I got involved shortly after I finished up my fellowship with the Barry trial. And so I actually think in many ways, most of the lessons about CABG and PCI are reflected here. So I'm going to spend a little bit of time on this because I happen to know this particular trial well. So patient entry was a while ago. It was in the late 80s, early 90s. They were randomized multi-vessel disease patients to either balloon angioplasty or CABG. And they also had, and this is a very interesting feature when you can do it, they had a registry of people who didn't make it into the trial but would have been eligible for it, but weren't chosen for a variety of reasons, and a selection of people who weren't eligible at all. And they've also did some interesting registry studies. This isn't done as much anymore because it costs money. So, but I think it's really helpful to put it in context when you can do a registry. So here's the inclusion and exclusion criteria for Barry, and they're just like they are for most of the other trials. You had to have angina or evidence of objective ischemia that required you to get a revascularization procedure. You had to have multi-vessel disease. Single vessel disease is generally off the table for most of these. And you ought to have anatomy that was suitable, that you could get a PCI if you were randomized to a PCI, or get a CABG if you were randomized to a CABG. So you had to have anatomy suitable for either one. So they did screen people in Barry and see how people got into the trial. And they were excluded for a variety of reasons. And most of the people were excluded because they had either a left main stenosis, or they didn't have enough angina that they absolutely had to have a revascularization, or they had some other life-limiting condition, and so on. So it goes down the list. And what you'll find is this is fairly typical for trials. They went out and looked at 25,000 patients, and about half of them met those clinical eligibility criteria. So half of them were clinically eligible. And then they looked at the angiograms, and 2/3 of them couldn't get a PCI, couldn't get into the study because they basically couldn't get randomized to either one. And this, I think, maybe that number is changing a little bit as PCI gets better, but still, some people are going to be out because you can't be randomized technically. And there are about 4,000 people who are eligible, and 50–60% of them will agree to be randomized, and the other half won't, or their doctors won't agree to have them be randomized or something. So many people make a big deal that, well, it's only 1,800 out of 25,000, so it really doesn't generalized, but I actually wouldn't read it that way, as we're looking just at that middle part of the spectrum where there's a real question about which way they ought to be treated. And those are the people who are included in the study. So it's really this group of people here that you're interested in. And yes, some people don't agree to be in an experiment. Yes, sir?
How many people went into the registry? Was it out of the 4,000 or out of the
all of these 2,200 people who refused in a sample of these people who were clinically eligible but angiographically excluded. I think 10% of these people were in the registry. And actually, I do believe that you could go out and get a data set right now with the old Barry trial and look at it if there were some interesting questions in it. I think it's one of these public use data sets from the NIH. So I think now that I'm saying this, I'm thinking I ought to go out and get it myself. It might be interesting to look at a few questions in there. So the baseline characteristics, about 1,900 people in each group, fairly typical, about early 60s, 3/4 male, half of them had a prior MI, 1/4 of them had diabetes, and quite a few had unstable angina, so they were admitted for some acute coronary syndrome and settled down but didn't have an MI. And you can see that 40% of them had 3 vessel disease, so 60% had 2, and they mostly had a preserved LV function. So you fast forward 10 years later, and these are the ultimate results from this after a long period of time. Obviously, it took a lot of people a lot of effort to follow everybody for 10 years. But what happened is, and you can see this here, is the dotted lines are the PCI, solid lines are CABG, and the CABG patients did a little bit better than the PCI patients after there's a little initial period here where the PCI folks do better initially, and then later on the CABG people catch up and run ahead of them. And that's a pattern you'll see a lot. And then they were just a little ahead, and this is not statistically significant, 0.018. And free of MI, a little bit more. You can see maybe a little more separation here with perioperative MIs, and then they catch up later, and it's pretty much the same. So the survival was slightly but not significantly better with CABG in people who you could go either way with. So that sort of suggests, well, maybe some of the other things were important, and this is one of the other things that's really important, is which one of these is better at relieving angina. And this is the percentage of patients who are survivors. Obviously, a person who's not alive does not have an angina problem, but who reported angina at the clinic visits at various times. And this stippled thing is the PCI patients, and this is the CABG patients. And there's two things you can see, is that there's a big difference favoring CABG. Fewer people had angina when they came back over the first few years, but the PCI numbers came down, and the CABG numbers came up over time, and so there's an advantage is there, but it's temporary for CABG. So CABG has an advantage for a few years in relieving angina, and after that, it's more determined by progressive disease and other things that go on. So the PCI people crossed over and they got on better medical therapy or had repeat procedures, and the CABG people had vein graft failure and progression and so on. And so after a while, they kind of equalized, sort of saying most of the action is in the first few years. So what I want to turn to, though, is maybe the most important finding from the Barry trial was not the overall result, but its result with respect to diabetes. And this gets into the whole problem of subgroup analysis. And how do we think about subgroup analysis and what's okay about subgroup analysis? And so if you go back and read the Barry protocol, and it says that we're going to look at these subgroups here, these angina, severity, number of vessels, LV function, blah, blah, blah. And diabetes was not mentioned, but the Data Safety Monitoring Board charged with watching this trial said, we are worried about the patients with diabetes, and so they added them at the beginning of the trial as a group to be followed and monitored. And it turned out that that was a pretty smart thing, because that was the group that showed the biggest difference at the end in survival. If you looked at people with diabetes, the 5-year survival rate for people with diabetes and CABG was about 81%, and it was about 66% in the PCI group. Huge difference. And in the people without diabetes, it's practically spot on. And obviously, the people without diabetes did a lot better than the people with diabetes. And the NHLBI issued a clinical alert about this diabetes finding to the world and caused a lot of people concern. I think we were talking earlier today in the clinical conference about the SPRINT trial and how the NIH announced the findings early, and was that whenever they do these clinical alerts, it causes a lot of angst in the community. So there was a lot of issue there about whether this finding was reproducible or not, and various people tried to look at it, and I'll get into that in a little bit. So the key thing from the Barry was, I would say, it was really important, given what happened over time, to get a long enough term perspective, because if you looked at CABG just in the first year, you wouldn't see the full survival effect until you've gone a couple of years, and you wouldn't have seen all of the stuff about the angina patterns unless you waited for a few years. So a long-term perspective is important, but if you wait long enough, things kind of equalize in the end. There is less angina after CABG for a few years, and CABG reduces mortality a little bit, but overall, but a lot in people with diabetes. Those were the conclusions. And I will just steal the thunder from later, saying I don't think that our conclusions today are any different than they were at the end of Barry. I think these are probably things that hold up, and I'll walk you through that, but I think that these are all probably all true today. Now, what I want to do now is just switch gears and talk about an interesting question that this Barry result brings up. Let's see, can I go back here? So I'm showing you the results in patients with diabetes, and it looks like there's a big effect in mortality here in the patients with diabetes, and not so much in people without diabetes. And so this is an issue with all clinical trials, is if we have a big clinical trial and we enroll a lot of people in the trial, we get a result that comes back and it says, here's the result for all 10,000 people in this group, in that group. And so the overall average in the trial could be because everybody is getting the same benefit or same treatment effect, or it could be that some of the people are getting a lot of benefit, other people are getting no benefit, and some people are actually being harmed. And what we're seeing is this mashup of all those things. And obviously, it would be really important for us to know which one of these alternatives was correct. So what we want to do, though, we do a clinical trial, and we only can afford to enroll so many patients. And so it's hard for us to find these second-order effects by just looking at any single trial. I think now every single trial you want to see probably has one of those forest plots, where you see the hazard ratios, and they almost always line up together, almost always. Very unusual for you to see much of a difference. And it's partly by design, because the people who you really thought the treatment wasn't going to work in, you probably excluded them from the trial to start with. Or the people you thought it was going to work great in, you took them out too. So the people who are left should be relatively homogeneous, but still we see some variation. But we really need a big sample size to detect variation if it's there. And one of the things I would say is that the best way to do this is to take data from multiple trials and pool it together, so that we can see what the effects are in subgroups of interest. And there's more statistical power when you have more numbers, because we're trying to find a small effect. We need very much statistical power. And there's better methods that you can apply if you can pool the individual data. And I'm not talking about group-level meta-analysis, which is what you see a lot in the literature, what I'm talking about is an individual patient meta-analysis. So that's the thing. Let me explain what we're looking for. And this is a very important concept from my point of view. The technical term is heterogeneity of the treatment effect. And the key thing to say is if we have a relative risk, the treatment has a certain treatment effect, we can express it as a relative risk reduction. And it might be that it works to the same way in everybody in the population. So you have a high-risk patient, the relative treatment effect cuts it in half, so we go from 20% to 10%. We have a big absolute risk difference. And if we have a lower risk group, it still cuts their risk in half, but we get a little less bang for the buck in the lower risk group. That's expected. Okay, that's a normal thing in all trials, is that we see that that forest plot, the relative risk reduction is the same across everybody, but you know, there may be a higher or low risk subgroup. That's not what we're looking for, is something where there's a so-called heterogeneous treatment effect, where here we have two groups that have the same baseline risk, but in one of them, the relative risk reduction is 0.75 and the other is 0.25. So what we see is the treatment works better in one group than the other. And what we're looking for is a test that will tell us that the treatment is working better in this group than that group. That's what we're trying to figure out. Does that make sense? I know what some people are looking like, I don't know if I understand. Okay. Okay, so we're looking to see, you know, if we're doing that forest plot, that those little lines, those things are off, you know, they're not in the same line. That's what we're looking for. So how do we do this statistically? One of the things you'll often see, maybe less so now because journal editors are attuned to this, is that it's not right to just look at subgroups alone, look at the men and the women and say, the p-value in the men is less than 0.05, the p-value in women is 0.14. So it works in men and not in women. That's not the way it should be done. The way you're supposed to do it is to test whether men and women are different from each other in their treatment effect. And the term of art is the treatment by covariate interaction test. So you'll look for that in the statistical methods to see whether they did a heterogeneous p-value. Okay, I mean, I can tell you at Jack, we look at this all the time. We have these papers that come in and they say that it's different than that and the other, and we look and they didn't do this. And we say, nah, it didn't, you know, we're not going to take that because that's not proving what they're claiming. So, so let me go back to this idea of getting more data. So this was one of the things that was one of the most interesting and fun things that I was able to do, but it was very hard. We organized a project to pool together all the data from PCI and CABG trials that had long-term follow-up and were large and in multi-vessel disease. So we got together 10 out of the 12 trials that had been completed, and they all agreed to send us some data, send me some data, and we got data on 7,800 patients, which is almost everybody who was randomized with about 6 years of follow-up. And for those of you who like the statistical details, I can fill you in on what we did, but we did do this interaction testing to see whether it was different between the different subgroups. Everybody gave us a data set that the same variables were in all the data sets. And here's the variables. You know, it's the usual suspects: age, sex, race, diabetes, smoking, hypertension, etc. We got the main factors, and actually one of our challenges is that not everybody measures everything in the same way, and we had to harmonize the way the data were collected. And we pulled it all together, and we looked at the analysis. And so here were our main results, was that the CABG had a slightly better survival over 5 years than PCI. The hazard ratio is 0.91. This is pretty much the same as what we saw in Barry. Death in MI, slightly better in CABG. Death and repeat revascularization, you know, much less in CABG because of repeat revascularization in PCI, highly significant. More angina in the PCI group than the CABG group, again, highly significant. If that was the only result we wanted, it wouldn't have been worth all the trouble. But what we were interested in is the subgroup effects. So we looked at each one of those subgroup factors, and we found that diabetes, in fact, was quite significantly different in all the trials. And the age turned up as being also a modifier of the effectiveness of CABG and PCI. And there was no difference on anything else we looked at, including whether a stent was used or not, 3-vessel versus 2-vessel, et cetera. And here's our forest plot. I was very proud of this forest plot. You can't read it real well from the back of the room, so I put these things here to show. Here's age, showing in the youngest patients, PCI seemed to do better. And in the older patients, CABG seemed to do better, which is kind of interesting. And here's the diabetes, yes, no. Everything else lines up. So we found that these, by pooling together all the trials, we were able to get enough power to see what was going on. And we did see there's some evidence that not everybody responds the same way, which is an important principle. You know, whether there's some other groups, I don't know, but that was what we found. So here's the data in numerical tabular form. hazard ratio is 0.70 in diabetes, 0.98 without diabetes. This is exactly the same if we throw out the Barry trial. We just look at every other trial besides Barry, we get the same result. And here's the differences with respect to age. I'll just say that the thing for diabetes also was subsequently confirmed by the Freedom trial. So Freedom trial showed that, in patients with diabetes only, the 5-year outcomes favored CABG by quite a bit for the hard outcomes, 0.005. So I think the conclusion there is the diabetes thing is real and is actionable, and we probably ought to pay more attention to talking about CABG in patients with diabetes. One of the other questions, though, from all this was whether we could go a little further, and we could have answered some of these questions without doing all the trials. I mean, I got to tell you that it was a major slog to get all the trialists to agree to share data. It was not a simple thing to do, and in fact, we tried to extend that, and we can't actually get some of the data from some of the more recent trials. So it's a continually difficult problem. And so it'd be nice to be able to do this kind of thing if we could just use registries instead or other kinds of databases. So what we wanted to do was look at this heterogeneity question, but in a larger data sets. And one of the issues is something I mentioned earlier, that we only put people in trials who seem to be really good candidates for the trial, and sometimes they're a little older or younger. I mentioned age. There are like very, very few people in any trial that were over 75. And I dare say you probably have more than a few people here who are like 80 years old who you have to figure out what to do with. How do we answer the question for those patients? We have in trials the usual kinds of things we say is, we have very selected people. We had the best clinics in the country doing the trials in these various places. What about average across the country, and so on? So what would be the results in more real-world populations is one of the questions from the registry. So we did a study that was using Medicare data that was real-world. We have very large numbers. We used a 20% sample of Medicare, and we looked at patients who were over 66 and older to give us a year's worth of data to look at, and had multi-vessel PCI or CABG. And the methods, I could spend more time on this, but we did something called propensity score. Is this a term that means anything to the fellows? Propensity score matching? A few people are nodding yes, maybe nobody wants to say no. But the idea is that you do a model to say what predicts getting PCI, and on individual characteristics, and you get a probability that you'll get a PCI, and you find, for everybody who got a PCI, you find somebody who had a CABG but has the same score. So you match them on propensity score. So they're equal probability of getting PCI or CABG, and we match them on the year the procedure was done and whether they had diabetes or not, and age, because these things were important. And then we looked at these different clinical characteristics in the data set. And we also wanted to get at this question about what about the average effect in the population versus individuals. So we actually used modeling to try and figure that out. We basically had a model of what would happen based on all patients, and we, for every patient in the data set, artificially in the computer reset their treatment from CABG to PCI and back and forth, and got how long they'd survive given the alternative treatment. So what we found in the Medicare data using propensity score matching was a hazard ratio for CABG and PCI was 0.92. We got 0.91 when we pulled the trials together. So we felt pretty good about that. That seemed to match up pretty well. And this is significant statistically because we had 100,000 patients instead of 7,000 patients. So, but it's the same treatment effect, okay? 5-year survival difference is about the same as we saw in Barry. It's about 2% different at 5 years. And we also found that there was significantly better effects in people with diabetes. There was significantly better effects in people with heart failure, which is interesting. Peripheral vascular disease, Alan Hirsch is not here, he would like this, is you know, works better in those people, and smokers, interestingly enough. And but the main thing is, and this is one of the more interesting things, is that when we did individual patient estimates, we found that 60% of the people did better with surgery and 40% did better with PCI with respect to survival. And here's a little histogram showing the estimated, this is the size of this is the percentage of the people in the cohort, and on this axis is the number of life years added over 5 years, like the difference in survival curves over 5 years. So this is 0 right here. So what you can see is there's a non-trivial number of people who are on the PCI better side, and there's a long tail, and there's some people who get tremendous benefit, a few people who get moderate benefit, and some people who get no benefit. So there's heterogeneity in the response to treatment. And so, you know, our jobs as physicians is to, you know, figure out whether you're over here or over here, and whether you're, you know, closer to here or way out here. And that's going to be very important. And what are the factors? What makes you on one side of the line or the other? So it's 4 factors. So people with and without diabetes. So if diabetes, no, this is the average effect in them. So more life years are added if you have diabetes, more if you were a smoker, much more if you had heart failure, interestingly enough, and peripheral vascular disease. And the 40% of the population who did better with PCI had no on all of these things. Okay, so it was that simple in our data. And if you want to, you can go and play around with these results on our website. We have a website up on the Stanford thing, and you can put in data here and play with it, and you'll get some 5-year survival estimates and show what the hazard ratios are, and also tells you whether there's estimates are based on whether we have a lot of people in our data set or only a few. Because, you know, the model could be run where we get 99-year-old people who are smokers and diabetics and so on, and there's nobody like that in the data set. So, you know, we don't want to push this too far. So we found, how are we doing here on time? We did find heterogeneity for CABG and PCI. We found it in the trials. We found it in an observational cohort. I think it's real. The modifiers seem to be the same in the things, especially diabetes. Age was an issue. You know, we need other studies to be sure of this. I think this is, you know, we hear President Obama and everybody's talking about precision medicine and how we can do all this stuff, and, you know, I'm all for it. But the idea that we need to do a gene test to figure out which individual benefits more from one treatment or another, I would say is not necessary. There's a lot of stuff that we can use to individualize treatment that's based on clinical factors, and I think that there's a lot of this that's out there right now that we could get at if we did more data analyses to look at these things. So anyway, I think the concept of individualizing and picking out the right treatment for the right person is absolutely spot on, but I think it's a misconception that it requires fancy genetic data. We just did this with data we found in Medicare. So
are we confident enough about this to use it as a clinical tool, or are we at the stage where we need a clinical trial to test its selection?
No, that's a very interesting question. So, you know, the idea, you know, this is an innovation. You know, I would say the insights are probably there. You know, in the real world, this only looks at survival. You know, it's not the only factor that matters to people. You know, recovery, the possibility of stroke or cognitive dysfunction, you know, the expense and other things matter to people too. So, you know, if somebody was in that zone where it didn't make a lot of difference one way or the other, you might say, well, you know, those other factors could push you one way or the other across the line. But, you know, if somebody was like patient with diabetes and peripheral vascular, and you really ought to talk to them about an informed decision about CABG versus PCI. And I think our healthcare systems are set up so that, you know, people come in and we often don't have those discussions with them. But, you know, we could know that beforehand and talk to somebody who has diabetes and peripheral vascular disease before the cath. So that would be my take-home message. I think we know enough to know that we need better conversations with people who might have extreme benefit from one treatment or the other. But, you know, should innovate clever things on, you know, mobile apps and stuff, should we test them in trials and other ways? Yeah, I would say that's true. You know, you're right to say, is this ready for prime time?
Well, it's very promising. I was just
a
footnote. I'm sure you remember the UCSF also found benefit in revascularization of CABG, especially prominent in this research. They obviously did not compare the PCI, but it was remarkable. Do you think that the reason younger people don't younger and less complicated patients, I'm assuming, do better with PCI is that they do have more focal disease?
You know, the one hypothesis I have, and is testable, but not with the data I have, is if we had gone in and really, all we have for the angiographic data in any of these data sets is 2 or 3 vessel disease, very crude. If we really, you know, Patrick Sorois and others would say, you know, if you had a syntax score, that would tell us what's going on, or a more detailed anatomy. You know, could we, in fact, explain the age effect and so on, because what that is those are people with very low syntax scores, because they're young and they only have like 1 or 2 lesions, and, you know, it's easy to fix, so they do much better with PCI. And it's that the old people have, you know, I don't know. It's a hypothesis that I think is testable, but that's the limits of the data that we have. I mean, you can only apply these statistics to the data that are collected. And you know, we don't know that.
On a social level, as in the medical society, we should move towards asking researchers to make their data available for patient-level meta-analysis.
I think the NIH and others should support doing it and try and make it. There are a lot of, like in the PCI trials. A lot of them were privately funded. You know, they were funded by stent manufacturers or something. You know, so you know, we had to deal with them to get the data, and so that's part of the issue. I think there's a real tension there about, you know, we're moving towards more open science and data sharing, and I think that's a good thing. But, you know, a lot of people will say, you know, hey, I worked on this study for 5 years, you know, you got to give me a chance to write a few papers here before I'm going to let the whole world at it. So, you know, that's the other tension in there. How do you, you know, give people the incentives to go out and generate the data in the first place, and balance that with the ideas of saying, you know, they're just sitting on all this data and they're not actually getting much done with it. So, you know, I'm in favor of finding mechanisms to do that. And it's surprising to me, actually, you know, we did this pooling project on a shoestring and basically couldn't get it approved. We didn't actually get real money to do that study, which is shocking to me. I mean, it seems like that's something that the NIH and others should fund. So, yeah. I have a few more slides I could talk about. One other question, or we could just talk some more. It's up to you. Gary, what do you think? Keep going. Okay. So I wanted to just talk for a minute, circle back to this idea of the moving target problem, and tell you about something else we did that I think is interesting. You know, it was very frustrating to me because every time we do one of these studies, and I see this for PCI, it's like the angioplasty community would say, well, that's great, except, you know, you're using the old stuff, you know, it doesn't apply today. And I got to be like, well, how do we analyze the question here if we keep tweaking our devices and our procedures? You know, it's like, okay, the device we're using now is not the same. So how do we compare these things? Devices and procedures are getting updated all the time. You know, a atorvastatin today is pretty much the same as a atorvastatin 10 years ago. Might cost something different, but it's the same drug. But PCI today and PCI 10 years ago are not the same. So how do we deal with that problem? And you know, 5-year follow-up data, if we need 5 years to figure out what's going on, by definition, it's based on technology that was used before 2010, right? because there's no way to get 5-year data without waiting 5 years. So how can we evaluate the technology if it changes over time? And so that's a catch-22. And so how do we deal with that? We had this idea. Well, here's my thought is that stents really coronary stents changed revascularization, but didn't change heart outcomes. And I think the data from trials back this up, but I couldn't get a lot of people to believe this. So here's a network meta-analysis on group data showing that if you compare bare metal stents with balloons, drug-eluting stents versus balloons, or drug-eluting stents versus bare metal stents, this is the effect on death, exactly spot on the line of no change, MI, almost the same. The big thing that changes is repeat procedures, which are much down with stents, but that's what they're designed to do. Nevertheless, there's still the belief out there that they've changed mortality and heart outcomes compared with earlier technology. And it seems to be a very hard idea to get outside. So we were interested in looking at the Medicare cohort I just told you about. And we said we had a bunch of people who got this stuff done while bare metal stents were used. And another bunch of people got it while drug-eluting stents were used. And CABG was used the whole time. So what we wanted to do was to say, well, let's just look at the CABG group and we'll just compare the PCI patients against the CABG patients. And if there really is this big improvement when we introduce drug-eluting stents, we ought to see a big uptick in the survival rates of PCI relative to CABG, coincident with the introduction of drug-eluting stents. So that's what we did. We did a statistical modeling thing where we're saying, let's compare PCI versus CABG and look for a difference in when we use bare metal stents, the difference when we use drug-eluting stents, and see if those two differences are different from each other. So-called difference in difference approach. And so we were looking for secular trends, and then we tested whether having a DES available changed whether CABG and PCI were. And that's a lot of statistics. Here's the survival graph, which is a lot easier to understand. So here's the PCI patients in bare metal stents in the solid line, drug-eluting stents in the dotted line, and you can see that their survival improved. But what happened, and if you look at the 5-year survival, it's better by 1.3%. The trouble is, or the good thing is, the CABG didn't sit still either, and those patients were better over the same time period by 1.1%. So they both got better. So the DES people are right in saying the DES patients are getting better, but what they're not saying is that the CABG patients are doing better too. So in a little race, they're both improving. And so this is plotting this difference between CABG and PCI in the two eras for death and MI, and repeat procedures. And what you can see is that there wasn't much difference in heart outcomes. There was in repeat procedures. And here's the hazard ratios in the forest plot. Exactly the same, no interaction with the era. But we detect the effect, as we should, for repeat procedures. So that you can pick up the effect of the drug-eluting stents on what they're supposed to do. So the reason I show this is partly to say, that I think the old studies can still tell us something, because I don't think that the technology changes have affected heart outcomes that much. They've affected a lot of other things. So I think we can still learn something from our earlier studies, so that's good. And this is a potential way to solve a lot of issues with technology change. If we can just monitor stuff over time and look for, abrupt changes coincident with the introduction of new technology. Yeah.
So how much of this do you think is that the patients with cancer, and how much do you think it was a change in background medical therapy?
Well, that's what I don't know. No, I think that's one of the big things that's going on. Everybody is getting more statins. Everybody is getting more evidence-based treatment, where we have better better supportive care. I would hope everything is getting better. So in like first-year epidemiology, we say historical controls are bad. Because a lot of things can happen, and so that's exactly what it is. PCI a few years ago was done with older equipment, but it was also done with older drugs and older other things too, and all those other things may have changed as well. So I do think this idea of using our registries, though, as a way to monitor continuously instead of doing a trial with a snapshot is a potentially powerful technique. So we ought to embrace that a little more. So I'm going to shut up. I'm going to say I hope you learned a few things from this. I think that we could compare the results of CABG and PCI and perhaps other things using both trials and observational data. I do think that there is evidence out there that clinical factors do modify, treatments don't work the same for everybody, and we can identify those factors with some careful analysis of trial data and observational things. I do think this pooling thing is a great idea, but I also think that we ought to make better use of our observational data and figure out ways to analyze the data we're collecting already and contributing to registries. And I thank you for your attention and for the invitation to be here.
All right, so we have time, maybe about 5 minutes for questions. And Dr. Hlatky.
In addition to changes in treatments and technology, there have to be some changes in the patient. For example, from the time that the very patients were enrolled to the present time, the incidence of diabetes might be twice what it had been. Are those new diabetic patients, do they behave the same as the very diabetic?
There's a few things that are changing between the population. Some of them are good, like reduced smoking rates in the population overall. That's good. The heavier patients and more diabetes, that's bad. A lot of these analyses adjust for diabetes in the population, so I think the time trends and outcome are still there, even if you subtract out that thing. But I do think that the challenge is just that we need to figure out ways to get insights that we can hold on to, even though we do have some of these changes over time in our patient population and technology. Is there like a clear-cut principle? And I think that CABG works better. I mean, what I take away from this is in really severe extensive disease, you're better off doing a CABG, and especially in patients with diabetes. So I think that's probably held up through multiple trials, and I think that's probably a take-home, and it's probably not going to change very anytime soon.
When it comes to CABG versus multilevel PCI for these patients, how do you account for the completeness of revascularization? Because the absolute disruption in mortality that's seen with CABG versus PCI is always very significant based on relative risk ratio, but just for survival, the absolute disruption must be 5% across most survival. Do you think the completeness of revascularization will sway things towards the PCI side?
I think it's, if you look at PCI, the question of the completeness of the revascularization is really there, because, that's just different the way things are done. It's sort of a bit of an inherent difference. I mean, in CABG, you only have one shot at it, so, they tend to do everything at once. And in PCI, people know they could go back, and so they maybe would leave something for another day. And so whether you need to do everything at once is a big question. And it does make sense to me that doing the most important lesions first would be good. There's a new trial, the FAME-3 study, which is looking at PCI guided by fractional flow reserves compared with CABG, saying maybe so it depends which kind of complete revascularization you mean. Is it anatomic or functional or what? It makes sense that we only doing the things that really need to be done would be a smart idea, but picking out the right ones is maybe the issue. So I think that I don't know how well the FAME-3 trial is doing in terms of recruitment, but it's a fourth generation trial trying to say, well, let's do it really smart with the PCI. But I think it must matter, and I do think that's part of the reason is that the revascularization is probably on average more complete. But that leaves a lot of individual variation in terms of how complete the revascularization was. Yes, sir.
There are any data about the female change to bypass the patient with very mild systemic PCI already has a let's say dramatic effect on their behavior and lifestyle because somebody has shifted.
You know, there's some interesting data on this. We did a study where we looked at medication adherence after revascularization, and this is in Kaiser, where they have a great integrated clinic, and they really push it. And it's very clear that the PCI patients get more medications afterwards than the CABG patients do. And why that is, I'm not sure. It may be that it's sort of like, okay, that problem is taken care of, thank you. And I don't need the medications now, then maybe that's part of it. And it may be a systems issue where, once you have the surgeon, is done and you don't go back and see them again. And, you kind of fall between the cracks even in a Kaiser. Whereas you go back and see your cardiologist again. So I think the medications are there, and maybe there's a little push to adherence in a PCI patient. So you better take your dual antiplatelet therapy, or these stents are not going to work. That might be more important to them. So I think there's really big potentially behavioral differences, and those are kind of averaged in the trial results that you see. Because if people stop smoking at different rates after the different procedures and so on, that's all part of the wash. Yes, sir.
Another question about your statistical method and pushing the data. So, like, if you say you're doing a binary yes or no, somebody has diabetes, you guys push the data to say if you have your A1C above 10 versus 8, and just keep zeroing in to find out which group is better, or are you just doing so much stats that you don't know what you're finding out?
Well, I think usually what it is if you want to drill into those variables and see what it is about it. I mean, is it control, which would be the hemoglobin A1C, but that's sort of like how did you do in the last 30 days, as opposed to like how many years have you had? I mean, is there sort of a pack-year equivalent for diabetes? It's that you would, maybe that's more important for coronary outcomes than what your control is today. I don't know, but with we usually don't have that kind of level of detail in the data. But that would be fascinating to look at if you had a bunch of people with diabetes and looked at their control levels versus duration or other factors. But no, I'm not sure what it is about it. Patients, it's just comes up every time, and it may well be, if we really look at their age, maybe it's all distal disease or something. If we get back to anatomy, maybe that's still part of it. I'm not sure. Or accelerated graft failure. I'm not sure what the answer is, but it's I don't know which aspect of diabetes is bad. Yes, sir.
I'm trying to keep with the topic that we discussed today. Once you make the decision to chloride, which method is better, bypass or PCI, but still comes in the first step is to be chloride in the first place. And let's say the data, the second step data shows for the heart failure patients to do that with bypass surgery versus PCI. Each trial is not show different in mortality. I think diabetes again, freedom and the body shows that bypass is better than PCI, and freedom is the same. The body 3D does not show difference in survival. So you bring me back to step number one, saying, are we in the way where we should retest those pivotal trials that were done in the 70s to see generally in hospitalization bypass is better in a new way than optimal informatics?
I think one of the questions, intellectually, I'm really interested in that question, and whether we're ready to do that, to say, we learned that patients with left main disease would be better off with surgery back in, from the early trials. Are we ready to randomize people to modern medical therapy versus, I'm not sure that many people would have a stomach to do that, but I do think, the question of whether, I think modern medical therapy is really good. and you could say for prognosis purposes, which patients benefit so much more by adding revascularization to therapy. There is this question that I think the gentleman before asked whether people are really going to adhere to their medications after their procedures. Do they, think that an open one. I mean, I do think the data are very good, and it's very good at relieving angina symptoms that are intolerable. You know, so I would put that off to the side and say, you know, somebody that's really having too much angina. The data are really quite good, that it's good at relieving symptoms and it's signs of ischemia, but the argument's always over survival extension. And, you know, in the data that I showed you, I mean, most of those people were not, it wasn't a huge difference, okay? I mean, we're talking qualitatively like you live a little longer with one or the other, but it wasn't like 5 years longer with one or the other. You know, so the other considerations are, so it might be reasonable to go back and do some studies. You know, I think in trying to do medical trials versus PCI has been very hard. And our reimbursement systems are such that we're rewarded for doing things, and it's really hard to see a lesion there and not want to do something about it. So that's another problem.
Any other questions? All right, if not, please join me in presenting this token of appreciation to our visiting professor and guest speaker, Dr. Hlatky.
Okay.